Hello, I'm Faith Rogers, host of today's program, COVID-19 Keeping Up with a Moving Target. As a note to our learners, we will begin publishing our educational series only once a week beginning in July. Please continue to join us on our full-length live and on-demand webinars as we continue to learn more about COVID-19. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC and AAPA credit, as well as AMA PRA Category 1 credits. Please visit our website for complete CE information. If you're tuning into our webcast, please click the red Claim Credit button in the webinar console to attest for credit. Otherwise, please visit covid19.dkbmed.com. Today's learning objective is to discuss the benefit of the casirivimab-imdevimab combination in patients hospitalized with COVID-19 who lacked SARS-CoV-2 antibodies at enrollment. This educational activity is supported by independent medical educational grants from Gilead Sciences Incorporated, Regeneron Pharmaceuticals Incorporated, and Eli Lilly and Company, as well as in-kind support by DKB Med LLC. All activity content and materials have been developed solely by the activity directors, planning committee members, and faculty presenters. With us today, we have Dr. Paul Auwaerter, Clinical Director of the Division of Infectious Diseases at Johns Hopkins School of Medicine. Dr. Auwaerter, thank you so much for your time today.
Yeah, thank you so much, Faith, and delighted you're joining us today for one of our COVID-19 programs. There's no doubt most people are by now very familiar with the dramatic decrease in the number of COVID-19 cases. Now, thinking back to a year ago, this also happened during the summer, but clearly one can see this has accelerated and the decline is more than we had seen a year ago, no doubt due to immunizations. If you look at people across the country in terms of who's been immunized, you can see over half have been fully immunized, although there's variability in states in terms of achieving these goals. But the administration's goal of having 70% of people in the United States 18 and up immunized by the 4th of July, I think most people acknowledge that we won't reach this. However, part of the urgency has been the viral variants, which of course have been part of the news for a while. But if you look at the United States, typically the areas that are going to be more orange, more red, more purple are where there's higher percentages of continued testing with high positivity rates. So this would be states that might have, or counties with more than 5% testing positive and so on. The number of cases still more than 10 or 20 per 100,000 per day. And the states that have these colors tend to be the ones with the lower immunization rates. And the concern, of course, is if, even though the numbers are dramatically down, from a numerical standpoint, additional mutations can arise. And what we're seeing in countries worldwide are especially vaccines that perhaps are not as protective, including inactivated vaccines from China, are having outbreaks despite achieving high rates of immunization, for example, in Bahrain, similar issues seen in Brazil, that perhaps against these variants, there are problems. Now, within the United States, this slide is the most current, but it still reflects data from over a month ago, where the variant that is now called the Alpha variant, the 117, made up most cases. But the more compelling concern, and the reason you're hearing some of our public health officials commenting on the need to continue getting people immunized, is the Delta variant is now up to 20% of cases. Now, the Delta variant is the 617.2. This is the variant that appears to be so common in India and in other countries, as well as the United Kingdom, and very quickly supplanted the Alpha or the 117 variant. So there's concern that this new variant will supplant the earlier ones, and this Delta variant appears to be even more transmissible than the Alpha variant. Whether it's more virulent is less clear, but this is a concern. Now, there may not be much ease in convincing people to be immunized, but of course, this kind of approach now, rather than mass immunization, is much more on the door to door and trying to convince people on a one-to-one basis. There were news stories recently where Anthony Fauci and Muriel Bowser, who is the mayor of Washington, D.C., both went door to door to try to talk to people and convince them. Now, this is all on prevention, of course, and trying to make sure the pandemic continues its positive trend. Some additional information's come out that I think is very interesting, and this is the monoclonal antibody cocktail casirivimab and indivimab, which is already with an EUA for treatment of outpatients. But this is a trial, a large one from a recovery, the pragmatic trial in the United Kingdom, that was a randomized trial looking at patients who received this with the primary outcome of a 28-day mortality among seronegative patients, meaning patients that typically haven't mounted immune response, which means they're probably in the first week of their symptoms versus all patients. And on average, the seronegative patients that received the drug had 7 days of symptoms, day 9 for all comers here, as you can see. And this might be a little later than what might be typically so in the United States. But importantly, if you looked at the seronegatives, you see the monoclonal antibody cocktail, it did have a impact on mortality. You see these curves, although this was mitigated in all participants because you had the seropositives that may have already engendered, engaged their immune system, but were more in that hyperinflammatory phase where these monoclonal antibodies probably have little impact. Now, my view from this is I think this helps reinforce the idea that here, even in the United States, that if you have people early into symptom onset, and this is more in 3, 4, or 5 days, especially if they have weaker immune systems, there may be a role for high titer convalescent plasma, or if this particular Regeneron combination cocktail also receives EUA approval for use in the United States. And then if you look quickly at some subgroups here, you can see for 28-day mortality, again, just a different view for about a 20% reduction in mortality that appeared to be significant. Discharge also appeared favorable, along with heading off invasive mechanical ventilation needs, as well as death on the lower. Again, if probably people are earlier, or those that are just not mounting immune responses. So I think there is a clear-cut role for antibody-based therapies. The questions that remain, especially if this is given license with EUA for treatment in the United States, are not everyone benefits. And so, for example, can we get rapid assessment and seronegativity, or do we only treat people in that first week of illness, and so on, remains to be seen. Another angle that I think is increasingly interesting are the large number of trials that have used immunomodulators to help impact that second week of illness that's more hyperinflammatory. Previous programs, we've discussed baricitinib. This is a similar oral drug, Janus kinase inhibitor, JAK1 and 2, called tofacitinib. That again downregulates the intracellular pathways that cytokines would otherwise activate. And this particular trial, published recently in the New England Journal, was conducted, I believe, in Brazil, and were given to patients hospitalized but not yet in the ICU or needing non-invasive mechanical ventilation. And they received this compound twice daily for 2 weeks, with the reduced dose if they had renal insufficiency, and nearly 90% received steroids as part of standard of care. primary outcome, as in many of these trials, is a combination of death or respiratory failure. And here you can see the primary outcome showed a nearly 40% reduction that was statistically significant and better seen perhaps by the graphs with the inset graph, nearly a magnification. Although on a secondary endpoint, death only was not sufficiently powered for outcome. Importantly, this trial in Brazil, many patients did not get remdesivir, which is not widely used there. So a bit unclear how this might manifest. Put into context with two trials which we've known about earlier with baricitinib, the Act 2 trial showed a one-day improvement when it was used only with remdesivir. Many people were at this point in time were not on steroids. The more recent Cove barrier trial suggested that patients that were on high flow oxygen or heading to the ICU did have an improvement, along with an improvement in all-cause mortality here that were secondary endpoints, although primary endpoints were not met, which, as we've discussed in earlier programs, is a bit of a mystery. But suggests that these drugs, in addition with steroids, may have complementary action, and how this might work and whether it should supplant tocilizumab, which is a more targeted and specific inhibitor of IL-6 receptors, is unclear. There's perhaps more data with tocilizumab than these Janus kinase inhibitors. But again, I think it could be we don't have comparative trials to really say one's better than the other. So I think tocilizumab has sort of been in the lead because there's more familiarity with it, but it'd be lovely to have a head-to-head trial to see if one might truly be a better use than another, especially if it's a more broadly immunomodulatory compound as these inhibitors are. So Faith, I think we have a couple of questions this week.
Yes, we do. Our first question is, will we be able to modify and distribute mRNA COVID-19 vaccines quickly enough to keep up with the spread of variants, such as the Delta one?
So I know the mRNA vaccine manufacturers have already stated such that they could change production in as little as 6 weeks. I know Moderna specifically is building new production facilities to deal with the need for booster doses. I think it remains unclear if there's sufficient a breakthrough, I'm sorry, of the immune responses to the existing vaccines that will need boosters. I think it remains an open question. But these companies are preparing now. How fast these can be manufactured to the degree of tens and hundreds of millions, I think, optimally means there will be a delay. The question is, when do you throw the trigger? Do you throw it in anticipation? Or do you wait until you have evidence? And I think this is something that we'll be looking at fairly carefully, especially in countries that are more fully immunized, such as Israel and some of the smaller countries that have good public health systems that have gotten these vaccines on a timely basis, as opposed to the UK where they've been spread out. So this is a highly interesting area, and one which will be some interest I am finding, whether you do something on a prevention basis, which I think many people would not be too enthusiastic, meaning you're going to get a booster thinking we might need it, as opposed to having a more clear-cut need.
Okay, and the next question, why is Oxford University investigating ivermectin in their principle, and how soon could we see preliminary data from this?
You know, ivermectin has had its proponents mainly based on test tube studies, in vitro studies, that suggested it inhibits viral replication. There have been some very small pilot studies, as well as observational or retrospective studies suggesting benefit. Some have used it quite widely, for example, in India, because of the lack of access to more traditional and recommended care. The best trial that I know of was called the EPIC trial out of the country of Colombia in South America with mild COVID, where there was really no benefit in those that got the drug for 5 days versus placebo as part of treatment. although some have criticized the trial as those were generally younger patients and there may have been some blinding issues. So perhaps, as always, it's not unreasonable to do another carefully and well-performed trial to see. Personally, I think these kind of drugs that inhibit more cell synthesis of new RNA and proteins are not as effective as targeted antivirals. So we may have an additional trial here, and I think that's probably the rationale to see if there can be something that is a bit larger to see if there's any benefit since there is an unmet need for an oral antiviral at this time.
If you're tuning into our webcast, please click the red Claim Credit button in the webinar console to attest for credit. Otherwise, please visit covid19.dkbmed.com. Any questions or issues, feel free to email us at the address listed. To submit questions, please send them to qa@dkbmed.com. That's Q as in question, A as in answer at dkbmed.com. Again, thanks for joining us and thank you for your dedication to your patients with COVID-19. Dr. Auwaerter, thank you again and we'll see you next week.
Thank you, Faith, and thank you so much for joining this weekly series. And please stay tuned for additional programs or feel free to look into the library for earlier topics.